everybody. My name is Valeria Ferrari. Thank you again for being here. It's a big pleasure introducing this special webinar with Dr. Bianco. And I would like to introduce a few minutes Dr. Bianco before starting, because this webinar is so important because we will discuss about Teethan in clinical research. So we will see some clinical cases from diagnosis, so especially for the analysis of TM joint disorder, and also some application in sport dentistry. So we will touch different topics that will be really interesting also because they are referred to a dental practice that is a daily dental practice. So Dr. Edoardo Bianco graduated in dentistry and dental prosthetics at University of Milan, and he specialized in with honors in 2017. He mainly works in implantology and gnathology, so what is related to TM joint disorder. He specialized in sports dentistry at University of Chieti. He holds also a master's degree in osteopathic matter, and with a focus on manual treatment of temporal mandibular joint. He is an adjunct professor at the University of Milan Bicocca and lecturer at SOMA, that is our Institute of Osteopathy in Milan. He is a member of AIG, that is the Italian Academy of Gnathology, and is also a member of Italian Society of Sports Dentistry, that is the CIOS. And is also author of several publications in national and international journals. So we have a speaker that is really interesting, and I'm super happy to leave the word to Dr. Edoardo Bianco. If you have any question or technical issue, just write all the questions in the Q&A section. I will read them at the end, so we will not interrupt the Dr. Bianco during the lessons. But anyway, if you have any issues, just write in, and I will answer to you. Thank you again, Eduardo, for being here. For me, it's
welcome.
A big pleasure because I know you from several years, and for me, it's really nice to have you here. And I have to say that we have different doctors from every part of the world, from US, from Mexico, from Europe, and also from China and India. So it's something that it's really interesting. So thank you again, and let's see, and we will wait for your lesson. Good luck.
Thank you, Valeria, for this introduction. And good evening, or good afternoon, or good morning to everyone here. My name is Edoardo Bianco, and I will speak about electromyography. And the title of this webinar is about research. But speaking only about research would surely be boring. So I would like to present it. I would like to present research through clinical cases, which are object of clinical studies, university studies. So we start with a clinical case, which regards athletes from the Italian national rowing team. Sorry. Okay, I couldn't see the title. The national rowing team, and we are in Lake Como because we worked together with the Canottieri Lario Sports Society, and we will analyze the concept of oral splint mouthguard. I called it oral splint mouthguard, or gnathologic bite mouthguard, because I would not like to call it only mouthguard, and I don't like to call it only oral splint, because it has a mix of the characteristics of both. Rowing, of course, does not require physical contact, but we want to protect our athletes from something, and later we will see from what we want to protect them. We want to analyze also the connections, the possible connections between different body areas. And for this reason is important for our mouthguard to have the best muscular work of masseters and temporals possible. And we will analyze it with the electromyography. And then we will analyze the influence of the occlusion of mouthguard on electromyographic indices. Oral protectors or mouth protectors have different functions. Of course, they have a direct protections from traumas, from injuries. They absorb energy, and they from an impact, and they protect so hard tissues such as teeth or bones, and also soft tissues like gums. And this is pretty obvious. But they also have an indirect function. They protect from sorry, I would like to hide something. I have too many squares activated. Okay, they also have an indirect function. And they protect from parafunction, from occlusal overload, and from TMJ trauma by deriving from compression. In Italy, we say stringi i denti, which means clench your teeth, and English-speaking people say bite the bullet. And in both cases, it's about teeth, because when you bite the bullet, you have to clench teeth. It means keep going in sport. It means don't surrender, focus your power, but actually teeth are involved. And when you clench teeth, something happens and something may suffer. And this is TMJ because of a possible overload. This is a magnetic resonance of TMJ, in which the condyle, as we can see, is slightly backwards compared to the correct position. And this could be the consequence of occlusal overload with the possible consequence of internal disc derangement. And this is representative, as said, as a patient may be suffering from overload. And at last, mouthguards can give an edge on performance, both psychologically and physically. These athletes we will analyze usually, all athletes usually train several hours per day. They do competition. So splint mouthguards protect, as I said, from injury and may give relief, but also protect, as I said before, from a possible overload. But and so we call it mouthguard. But I said that it's nice to call it also oral splint mouthguard. And what is the word oral splint related with? It is related to a connection between different body areas, because if we call it oral splint, it means that we want it to have the best possible muscle balance that we can obtain. When we say bite the bullet, we have a parafunction. I was saying that oral parafunction during sport gesture is quite common, because it helps to mandibular stabilization. It improves resistance by channeling muscular strength in other regions. In clinical research, connection between occlusion and posture, also in literature, was deeply analyzed. And it is a very treacherous path to walk into, because a lot of things has been said. Someone says that there are connections, other people say that there aren't any connection. What we can say from a very objective point of view is that there are for sure anatomofunctional connections between mandible and the hyoid bone, for example, or between cranium and occipital bone and clavicle, scapula, or lumbar girdle. And these connections can be seen on the left side of the slide, and with the functional triangles from Landouzy, as written on the lower part, which was a French osteopath. And they represent how different body areas are connected. Athletes train several hours per day, and coordinations derives from contractions of several muscles together. This is obtained by training. But pre-existing alterations or pre-existing torsions in maybe in the mouth or in the head district may give origin to postural compensation, and so it affects the movement. It is said in a book that I love, which is written by the Italian Society of Sport Dentistry. So we started this introduction to start to speak about mouthguards. A very fast introduction about mouthguards. They usually are formed by ethylene vinyl acetate. They are thermoformed, and the impression, the best material to take the impression is a silicone or polyether, better than alginate because it's more precise. And after the impression, after our mouthguard, our splint mouthguard has been made, we have to check if it is correctly balanced or correctly done. We can use electromyograph like Teethan, and also we can use some burrs to adjust the bite if in some places does not fit correctly, or if there is some points with the higher points, higher occlusion in some side. These burrs are made especially for silicone materials. To check if the occlusion is correct, we have to make the patient to wear our mouthguard, and then we have to make our patient to do some movements, to clench and to slide on the left side and on the right side, so that we can check also the canine guidance and the incisal guidance. We obtain these blue and red, blue dots and red stripes. And then with the burrs I said before, we can analyze if there are some points higher than others, and we can adjust our splint, our mouthguard. We can do that inside or outside. This is to make it fit in the best way possible and to have the best balance possible. And this balance, we can then check it via electromyograph. This is the final result. Also, dental wax is pretty important because the dental technician can imagine the three-dimensional position of both lower and upper arch, but maybe he does it in a manner that is not correct. So wax, an occlusal wax, can give him exactly the position of the lower and upper arch. And as we said about research, we will cite some research before analyzing our athletes, our case report, because we started from this article present on PubMed to our studies. Our idea became after reading this article. It was very interesting to notice that an occlusal disturbance may have a negative impact on the athletic performance of young elite rowers. They studied it with a leg press machine. We did it in a different way, with a different machine, a rowing machine. And we used an electromyograph, as said, Teethan, and I like Teethan because it gives us repeatable and objective measurements. In fact, an article of 2009 said that there were no statistically significant differences between test and retest values during the same session or after a 6-month interval, which means that even after 6 months, the protocol on which Teethan is based gives us reliable values, reliable indices. And then, based on this protocol, gives us qualitative and quantitative measurement of muscular work, such as muscular recruitment and asymmetry. The values given by Teethan I will try to explain them briefly when citing them, because in a few minutes we will see some tables with those values, and probably it could be quite difficult to understand if no one has ever seen an electromyographic report. But I'll try to do my best. So this is one of our case report of this athlete. He won the silver medal at Budapest Young World Cup of rowing. This is the table said before. I'm sorry that some words are in Italian, but I couldn't translate this image. By the way, the numbers circled in red are the values when the patient didn't have the mouthguard, while the values with the mouthguard are circled in blue. The first analysis was made with the patient normally seated. I called it normally seated because he was on a chair. We noted good global muscular balance, but this balance improved with the mouthguard, and we can see the values circled in blue are all written in black, which means that they are in normality range, in normal range, while the values, the indices written cycled in red, two of them are also written in red, which means that they are quite far away from normal values, normal range. If then what we wanted to do was also to analyze not only how the mouthguard worked when the patient was seated, but how the mouthguard worked when the patient was doing sport activity. So we used a rowing machine, as said before, like that in the picture on the right side. And we the athlete, asking him to sit in the position in which he expresses the strongest power possible, the position in which he does the bigger effort for the athletic gesture. And we see interesting things. As before, red circle values are those without mouthguard, blue circle values are those with mouthguard. We see that there are not an improvement like before, but a worsening. And that was really interesting to analyze. We asked why. With the coach, we saw that this guy used to do sport activity with his head slightly bent on the left-hand side. And so all these values were out of normal range, and this was quite strange. We asked ourselves what to do, if to keep the bite like that, the splint like that, or if to change it. But if we modify our roller splint, he will surely keeps his torsion, because a head bent on the left-hand side is a torsion. This torsion can spread to other districts. Maybe if we adjust the bite, we could reach all the values in the normal range, but this thing would not be okay for his sport activity. And so what could we do was speaking to the coach and asking him to analyze this situation with maybe an orthopedic, a physiotherapist, an osteopath, because we noticed this, and it was quite interesting. But then what to do was, of course, out of our range of activity. But by the way, the bite, the mouthguard was okay, because when trialed in a seated position, all the values, the upper analysis in this slide, all the values were inside the normal range. And we noticed that in sport dentistry, communication between different professions is very interesting. It's very nice to have, because you can learn a lot, like in this case. because then I understood, I asked the coach, which I am still in contact with, what happened to this guy, and they are trying to put his head in the straight position during a training, and no one noticed it because I didn't put a picture because it could not be noticed from a picture. The head was in a very slight position, bent on the left. But thanks to the electromyograph, we noticed this thing. And for sure, it is a nice catch in sport medicine. We have also to speak about the indices, as I said before. BAL is POC is percentage of overlapping coefficient. It means if the right side, temporal and masseter, TA stands for temporal and MM for masseter, if red or left masseters work in the same way or one works more than the other. BAL is barycenter. If both masseters work more than temporals or vice versa. Tors is torsion if the mandible tends to slide to the right side or to the left side during the clenching. Imp is the impact, the maximum voluntary clenching expressed, the maximum power expressed. And we see impact in percentage, but in this value appearing now, it appears also in absolute values, in microvolt per second. It is very interesting, these absolute values, because we see that this guy has more or less double microvolt power when he's wearing the mouthguard compared when he's not wearing the mouthguard, because it is smooth. And also, as we said before, when you do sport activity, you grind your teeth, you clench your teeth, you bite the bullet. So athletes used to do so. When biting a soft texture material, the impact increases a lot. We will see later that in athletes, the impact values, the impact absolute values are very much higher than the rest of population because they have generalized upper tone of all the muscles, but we will see it later. The second clinical case is about another guy, another athlete. This case was much more easier to analyze and to understand. We can see that on the right side, so with mouthguard, all the values are inside the range of normal range, except impact. As said before, during activity, the impact increases. So this is why I focused and I put attention a lot on having well done mouthguard without torsion, because torsion can spread to other districts if they are present. He also was in the national Italian team of rowing. As said before, an athlete is encouraged to clench on a soft texture, and our mouthguard made by ethylene vinyl acetate is quite soft. And in his case, the impact in absolute values is not as much higher as the athlete before, but probably this is a peculiarity of this guy. When he is seated, EMG electromyographic indices are within normal range. In position of maximal exercise or maximal power express, there is stability, and also, as said before, impact is stable. As we can see on the last line with the 3000 microvolt per second, it does not change with or without mouthguard. And all the values more or less stays in the normal range. So this guy probably does not have any parafunction or any strange position of the head or of some other district of the body, fortunately. But what can we understand after seeing these two cases? So after this introduction, a bite mouthguard, I continue to call it bite mouthguard, even if sometimes I say only mouthguard maybe. It may be a reliable device to protect our eye cave in both direct and indirect way. As said before, indirect way is, for example, protecting from parafunction, from excessive, an excess of clenching. But when not properly done, a mouthguard may interfere with the whole system. The whole system is our body. We can consider our body a system. All osteopaths consider the body as a whole unique system. It can interfere with its neuromuscular stability if not carefully evaluated. That's why not only an electromyograph could be useful, but also a stabilometric platform to understand if these possible changes, this possible adaptation, postural adaptation, also are expressed in fit power, in fit how the patient stands on the platform. And there is the possible consequence of a worsening of the athletic gesture and the increased risk of injury if our mouthguard is not made properly. Or also there is a possible worsening of the athletic gesture if the athlete itself doesn't have a proper occlusion. We cannot call it malocclusion, but maybe we can call it occlusion that gives origin to postural adaptation. Because as said before, it's difficult to analyze a relationship between occlusion and posture, but we can say that the head is connected with other districts via the functional triangles seen before. It is important also to analyze the athletes from physiotherapeutic osteopathic point of view for this reason. I will show you a single case later with an athlete of a different sport, which was also analyzed with the stabilometric platform. But to go deeper into the concept of well-done mouthguard, splint mouthguard, we have to speak a little bit about myofascial chains. They are chains of muscles that work together. Those myofascial chains from myofascial area must be free from any static adaptive compensation, such as a mandibular torsion, because if this happens, the movement could be a resultant that reflects internal problems. And this may lead to less efficacy and less effectiveness of the athletic gesture, deriving from asymmetric muscle contraction, deriving from adaptive compensation. As we can see in the right side picture, a torsion on the mandible right side, on the upper area of the body, may lead to torsion in the lower area of our body. So when we bite the ballet, it is very important that this is done properly. If not, this may cause cervical compensation or dorsal compensation or lumbar asymmetry, leading to a worse sport performance, because maybe we are doing a sport which requires a very powerful strength in our legs, and if we have a torsion, part of the power expressed is used to compensate this alteration, this postural alteration. So we have a less effective sport gesture. We need protection, as said before. We need the masticatory muscle symmetry, and this to have a better muscular recruitment in other body areas. And I am happy to repeat this more times, because I see that the number of participants of this webinar is increasing constantly. So maybe someone lost part of the initial discussion, and I can do a brief review. So energy optimization for a more efficient athletic gesture is what we are aiming to, according to Italian Society of Sport Dentistry, sorry. And also occlusal stability. This university work, which I translated only the title, won contest, Best Young Dentist, by the Italian National Dentist Association, and was made by me, a colleague, and a student who she is also a colleague now, because she graduated, and this was her degree thesis. We analyzed a possible muscular imbalance in the myofascial area in boxers and how this can affect the athletic performance. So we performed an instrumental evaluation with the electromyograph, and we evaluated the muscular balance of different mouthguards, and we performed an analysis with Stabilometric platform of the improvement of the postural stability wearing mouthguard. We analyzed different types of mouthguard, actually. We had 42 athletes from 2 different sports societies. The mean age was 22. They were quite young, and they had similar training modalities. What is pretty interesting to say is that we used a questionnaire, which is maybe the best and the most complete and questionnaire of gnathology actually present in literature. Is the diagnostic criteria for temporomandibular disorders. For those who do not know this questionnaire, I recommend to search it on the internet. I actually may put here only 2 pictures about it, but the whole package is 92 pages. And it is really, really effective in analyzing all areas of gnathology, and also from a psychological point of view. By the way, the only things that interested us were the pain in temporal muscle, the pain in masseters, and the pain in TMJ. And when we analyzed the patient, after seeing that he was not pathological, we proceeded with the analysis on his mouthguard. We saw that these athletes, were 3 types of mouthguard. The first one that we can see at the top of the slide was a stock mouthguard. Is the one you buy. You can also buy it via e-commerce. It cannot be modified. You buy it, you unpackage it, and you put it on your teeth. It is very uncomfortable. It does not have any stability. Better than this stock mouthguard is the boil and bite mouthguard, in which at least boiling it in hot water, it can mock your tooth position, and it has an increased stability. And then also custom-made mouthguard. This is, of course, you can now understand the type of mouthguard that I want at least wear, because the first 2 are not good, but also with our electromyography, we did the trials in a standing position that we call rest position, and in upper stance, which is a position that athletes of boxer usually have when fighting. We analyzed them in maximum voluntary cleansing, MVC, with mouthguard. All of them had a boil and bite mouthguard, mostly all of them. That's why we thought to expand this study, asking them if they knew that there was the possibility to have a custom-made mouthguard. By the way, even if this boil and bite mouthguard, even if I say that is not the best solution, we noticed that from a statistical analysis with the Wilcoxon test for pair data, that torsion, we said before that torsion is one of the electromyography indexes, impacted both in upright stance and in rest position, and also the global index of neuromuscular balance, which is a global index of all the other values, they had statistically significant improvement with P lower than 0.05%. I made a mistake in writing. So it meant that even a boil and bite mouthguard, the one in the middle with the yellow light, could be effective in improving the electromyographic indices, in helping us in what I said from the beginning of the webinar, to have to cancel all of the possible alteration and torsions on the oral cave. Then one of these athletes was also, he was the only one wearing a custom-made mouthguard after our study. I analyzed it. He was also doing orthodontics, and that's why he was wearing a mouthguard. In this case, is not the best solution with brackets because they can really harm your lip. But it was his life and his sport, so I tried to protect him in the best way possible with this mouthguard, custom made, and this is briefly explanation how it is made in this drawing. It has to protect the hard tissues, but also has to protect for 3 or 5 millimeters also the gum, because after receiving a punch, for example, the lip against the bone may harm yourself, while if there is this sort of pillow, this mouthguard between the lip and the alveolar bone, all of the tissues are better protected. And I analyzed him also with stabilometric platform. With the electromyography, as before, the red circled values are those with the mouthguard. The blue circled values are those without mouthguard. There is an improvement with mouthguard, as we noticed also with the rowers. There is an increase in impact. So do you see that we have more or less the same pattern in all athletes, because it means that electromyograph works well, that this protocol works well, and also that wearing a mouthguard, which is well balanced, works well. But this is the report of a stabilometric platform. Do you remember when I said that the mouthguard can be adjusted if in some places it appears too high or too low? Well, it is difficult to understand this report. I am also not an orthopedic. It is difficult for me to properly completely understand stabilometric platform report, but we can analyze two values. Unfortunately, they are written in Italian, but COP distance, center of pressure distance on the left side, circled in red, which means the center of pressure is the barycenter, and it reflects the sway of the patient when standing in the platform, on the platform, and also the other value written in cycled in red on the upper side, superficie ellisse. It is the total area of the oval deriving from all the points of the center of pressure. We can see that these values, the first line is without the mouthguard. The second line, the one appearing now, this one, is with the mouthguard, but with the mouthguard not already checked with the burrs. So we can see that the COP distance on the left is higher than the COP distance of the first line, which means that there is a worsening, because when the COP distance is very low, it means that the patient don't sway, and also the area is different. When the patient does not sway, it means that he's more stable. You can say that on the left side of the mouthguard, there's a sort of hole I created, because in that point it was too high, and the lower teeth made pre-contact, greater contact on this area, and this was not good, as seen in the Stabilometric platform report. After adjusting it, we obtain better values, lower values of distance, thus meaning a lower sway. We are speaking in this webinar of research, so I have to cite about Stabilometric platform, an article that I contributed to do, in which we analyzed with the Stabilometric platform athletes of different sports, and we noticed that a significant association emerged between postural interference, really noticed with Stabilometric platform, and the temporomandibular disorders, which means that, as I am saying since the beginning of the webinar, when there is a problem on the head district, oral district, it can also affect other areas. And this study, after a lot of analysis on athletes, showed that this was true, that there were a significant association between postural interference and temporomandibular disorders. So patient with a clearly diagnosed problem at TM joint had postural problem we noticed with Stabilometric platform. Also other studies, I'm not sure to speak about them all, but a lot of studies were made about mouthguard and sports dentistry. The aim of all of them was to analyze the muscle balance. Also in other districts, such as this study analyzed the kyphotic angle. So in the leg district, or analyze the pelvic torsion. So there are a lot of districts that can be analyzed in different ways, but we are dentists, so we just focus on the oral cave, checking with Stabilometric platform if the problem is spread also from in the lower part, maybe in the feet stance on the platform. So I will go ahead, I will not read all the article. You remember when I said that most of the athletes of our study, or of all of the boxers, used the boil and bite mouthguard? Well, we asked about the disadvantages and advantages according to them. They noticed that the boil and bite mouthguard give a breathing disadvantage. They didn't like how they could breathe. So it can be understood, because it is, even if boiling it, you can slightly adapt it to your teeth. It is not a custom-made mouthguard, so it is better when you have a custom-made mouthguard, of course. And all of the athletes, all of them who tried it after the study can confirm that a personalized mouthguard, a custom-made mouthguard, gave them better performance, better feelings. In fact, when we asked if they knew that a customized mouthguard can be made in dental clinics, most of them said no. So that's why I also wanted to say to dentists to speak to coach, sport coach, or to parents or people who have care of the caretakers, people who have care of children who practice sport, that mouthguard can be very useful, even better if it is a customized mouthguard. Another clinical case, we change sport again, cyclism. This is a patient which did not perform cyclism at but he presented at our clinic for a not gnathologic problem, but for a gingival recessions and infiltration of cervical restorations. So he didn't like his aesthetic. So the aim of this case report was to understand that occlusal overload can also damage not also TMJ, but also periodontal structures, occlusal overload and muscular hypertonia. Then a pressure-formed night guard can protect and improve in electromyographic indices. And a gnathological and surgical treatment of overload damage can be done together also to treat the aesthetic problem that the patient exposed to us. These are his pictures at the beginning. We can see that there are recessions in at least 10 teeth with restorations that are infiltrated. So he was treated maybe badly before. And we can see also bad oral hygiene in the lower arch. And those periodontal problems on the upper arch are probably related to a condition which is named abfraction, which is the pathological loss of tooth substance caused by biomechanical excess of loading force that results in flexure and failure of enamel and dentin in a location away from the loading, which is the cervical area, because it is one of the most fragile areas in the teeth. So before seeing how I treated this patient, I want to cite a study made in our university a lot of years ago about gingival recessions in athletes that performed horse riding. We noticed that athletes that performs horse riding had increased recessions of class 1, 2, and 3 of Miller compared to a population with the same characteristic that did not practice any sport at a high level. Why? Because I will explain it later. Athletes have higher muscular tone compared to non-athletes, also in muscles different from the areas which they train in sport, which means that also in the oral cave, so muscles, masseters, and temporals, they express a bigger power compared to non-athletes, even if, of course, they do not train masseters, they do not train temporals, but because of their athletes, they have a generalized hypertone, muscular hypertone. In fact, red and blue graphic is the athletes, yellow and green non-athletes. And in this graphic, I am analyzing the impact. As said before, is the maximum force expressed in microvolt per second. So higher core muscle tone. My patient, this is the electromyography report of the patient I was speaking before. We can see that he had a very high impact with high values and a lot of other values not in normal range. So that's why I also wanted to correct these values. Let's go back to this situation. I wanted to treat it surgically with the root coverage. So at first we have to remove all the restorations. So you can perform half a partial thickness flap, then create a smooth surface that is properly made to, I can say, to suitable to receive a graft, and we can do this with the specific burrs. And so we are in this way we are also removing all the restorations. And after partial thickness flap, we put on the root pref gel. Pref gel is a neutral ADTA chelating agent. I'm speaking a little bit about surgery now, but because this is a part of surgery which I think is very strictly related to gnathology and to sports dentistry. And also, as Valeria said, I also specialize in surgery, so I like also to do this part in this webinar. So pref gel is a neutral ADTA agent, a formulation intended made for topical application onto exposed root surfaces during periodontal surgery to remove the smear layer. We pick this connective graft from the palate. Then we also have the photo of the palate later. And then I put Straumann Endogain. Endogain is a gel containing enamel matrix products. And it is a mixture of proteins that can induce biological processes. And they stimulate the processes that usually take place during the development of the periodontum, and may stimulate the cell regeneration, and they may stimulate the healing process of soft tissues and also of hard tissues. So we put the end, and above endogain, we put our graft, our connective graft, kept into place by a suture, a nylon suture. Also, the palate is very strictly closed by stitches. And we wait for the healing, and this is the final result after removing the stitches, and this is the final result at 1 week. And also the other side was treated in the same way, and I think after a few months after the healing. So we obtain a very nice aesthetic result. We repaired the damage caused by overload, but now we wanted to prevent a new damage. So we wanted to protect his teeth by, this is not a mouthguard, because now the patient is not performing sport activity anymore, is older than once. So it is just thermoform EVA, we can call it night guard, that can protect from overload in athletes. In fact, in the lower right side, I said what some reflection, some thoughts that can do a resume of the whole webinar. They can protect from an overload which in athletes is higher than in the rest of the population. Then can prevent new periodontal damage, because I treated it with quite difficulties. And then this night guard is important to protect from bruxism or clenching, because not only the periodontum can suffer, or the TMJ can suffer, yes, we said it, but also the teeth may suffer. They can go through erosion, and they can lose their original anatomy. With this night guard, as we can say in the table on the lower part of the slide, the electromyographic values of my patient improved significantly, because all of the red indices became black, which means that out of the range of normal range became into the normal range. And also the impact, we obtained a lower impact, because it was not a smooth, a soft night guard. It was the opposite. It was quite rigid, hard. So the impact in this case became lower. So the patient could express a little bit less maximum force on his teeth. So we can conclude saying that the best protection for TMJ and for the stomatognathing system are a physiologic muscular work, with a balanced and stable occlusion, with vertical dimension, with a correct vertical dimension, and a correct guidance. The guidance can be obtained also with an oral splint, with our splint mouthguard. We said before that I checked the canine guidance with lateral movements. In fact, if this is not enough without a splint or without a mouthguard, the patient needs an intraoral splint or a mouthguard. Obviously, we also need to consider the patient as a system, a very big system made with different parts, and it is a functional system. In physiological condition, it works very well. When we alter something, he loses some effectiveness. He can lose postural. He can go through postural compensation because he's not as stable as she could be. It could be. So to avoid the risk of not considering dysfunction, is important to analyze also postural compensation with the Stabilometric platform. But since we are dentists, electromyographic remains the best mean we have to check the muscular function, to check the muscular balance, and to avoid that torsions or problems deriving from the oral cave and from occlusion may interfere with the other areas. In sport dentistry, thus creating a worsening of the athletic gesture. In normal life, it can create a dysfunction, maybe in other areas like pelvic region, for example, or the cervical region. This is quite common. So I really thank you a lot. These are the last images about what I use, as I was saying. And thank you for your attention, and I was pleased to speak with you tonight, or for tonight for me, to this afternoon for somebody else. Goodbye.